Carnivore versus Cardiologist. Oh my goodness, what happened? No, I'm totally kidding. This was a super cool interview. This was Dr. Tro out of New York. I'm Dr. Allo out of Toledo, Ohio. I found out we have a lot of similarities. Obviously, we have some differences. I found out we're both about in our 40s. We're both in private practice, which we had some really neat conversations about on the program as well as off the air a little bit. I highly recommend, if you guys have an option, to see a private physician. They just go more out of their way for you. They're not pressured by these huge corporations to see you in 5 minutes and bring in the next doctor, bring in the next patient in a minute and 30 seconds, all that kind of stuff. He also has an app. And I have an app. You can download the Dr. Tro app. You can download my app. It's Dr. Allo, DR space ALO. Download it whichever kind of phone you use. We both have lots of instructional and educational material on there. In my app, for example, you can watch videos. They're all free. They're all courses on POTS syndrome, EKGs, how to read an EKG, diabetes, hypertension, atrial fibrillation, blood thinners, how to lose weight if you're pregnant, my exercise program, exercise for the elderly, exercise for the young, all kinds of neat stuff. His app also has a lot of super neat and cool information on there. Like I said, he's based out of New York. Go check him out. This originally aired on his podcast called the Low Carb MD podcast. And this is airing on my stuff now, which is the Dr. Allo Show. YouTube, Apple, Spotify, Google, however you normally listen to your podcast. The video version is obviously on YouTube and video types of platforms, and the audio will be on whichever audio podcast listener you use. Super cool interview. I was very impressed because not a lot of primary care physicians know or are familiar with the cardiology studies and data. And, that was kind of impressive that he, knew some of the studies and trials. Now, obviously, for a cardiologist who teaches, at a teaching institute, it's pretty normal for us to rattle off studies. Well, this study showed that, and this study showed that. That's pretty normal for us, especially if you're in a teaching institution and you got fellows that you teach. Fellows are future cardiologists. They're cardiologists in training. They call them CIT, cardiologists in training, or FIT, fellows in training. But that was kind of neat. Definitely, we butted heads a little bit. We agreed on a lot of topics. We discussed everything from statins to heart disease and whatever. I'll give Dr. Tro a lot of credit. A lot of people, when they ask for an interview, usually I don't do them because most of them are a bunch of nonsense. But usually when I get asked for an interview, not usually, but sometimes they'll send me a thing like, tell me what studies you want to discuss. We can only discuss 3, or send me the studies you want to discuss first. Like, look, I don't have time for this. I have no idea who the hell you are or what studies we're even going to bring up. It depends on what topic you bring up. I can rattle off studies from the 90s and 2000s off the top of my head because I do this for a living. This is literally my job. If you're going to sit here and try to limit the discussion to some limited weird topics or studies that you thought of, we're not going to have that. It's just, this sounded like a conversation between two good old friends. It's almost as if we went to med school together and graduated at about probably the same time. And it was super cool. I think you guys will enjoy it. It's enough of me blabbering. Follow Dr. Tro. He's on every app. Follow me as well, Dr. Allo. It's kind of cool that both our names are just 3 letters. That was kind of interesting. And they both rhyme. They both end in an O sound, which was also interesting. Obviously, he eats a low-carb keto-style diet, and I recommend a more Mediterranean-style diet. Do what you want. You can read the data on both. We didn't really get into that a whole lot. He obviously has very strongly held beliefs about that type of diet, and I have very strongly held beliefs of my type of diet that I recommend, and I've tried all of them. I've been around since the 90s trying the Atkins and South Beach and all this kind of stuff all the way through keto. But anyways, check it out. I'm going to stop blabbering. Hit the view button or keep watching, subscribe, whatever, notifications, all that fun stuff. And check us out. We're both on every app. Have fun.
Welcome to the Low Carb MD podcast. This is going to be lots of fun. Dr. Brian Lencius is going to be so upset that he missed this. I'm Dr. Tro Kalasian, and we are joined here by Dr. Mohammed Allo. You may have seen him on social media. You may have seen him on his TikTok lives or YouTube. He is a cardiologist from Toledo, and he started his career at Midwestern University, doing his med school, internal medicine residency, and cardiology fellowship, all at that location. And he's been practicing in Toledo, Ohio, as a cardiologist in private practice, a dying breed, for the past, what has it been, 12 years, Dr. Allo?
12, yeah.
Yeah, I got that one right. That was a guess. So I'm happy to have you here, Dr. Allo. Maybe you could fill in some of the resume that I missed. And then maybe we can start off, because I think people who listen to my podcast probably know that we're going to disagree on several things. So maybe you can clarify probably the points you think we agree on. And then before we get into that, I'd love for you to just start basically and answer the question of what brought you into medicine. I remember reading your bio, and you were an economics major. So what made you sort of switch, or what sparked a passion to go to med school, and how has that changed over time?
Yeah, well, thanks for having me on. I'm super appreciative. So in high school, so my dad's a doctor, and I always wanted to be a doctor because I looked up to him. Great guy, he did a lot for us, and it really was nice. And I always looked up to physicians. They were nice, kind people. They're compassionate. They helped a lot of people. That was kind of their what they did. And surgery just seemed to me like it would be something that I would enjoy. I ended up not enjoying surgery. I actually applied to a bunch of surgery residencies. I actually applied to like 30 of them. And then, last minute, one of my last rotations was cardiology. And I was like, dang, this is really awesome. I would enjoy this way more than surgery, cutting into people and taking out infected, nasty gallbladders. Although it's great, I didn't feel that it wasn't as attractive to me in terms of like the way I think. That's sort of like, you're fixing problems that exist rather than maybe, getting ahead of them and trying to prevent them. Economics is the study of decision making. I had taken a class in high school that was like a economics 101, almost stock type of picking class where you had to try to beat everyone, and I did. So when I went to college, you could pick any major. I did all the biochem, organic, whatever, all the prerequisites for med school, but I took a lot of economics, and my economics advisor thought I was crazy. He's like, you're taking the hardest possible electives. It was like biochem, organic chemistry, whatever else. I forget what it was. Physics, the crazy hard classes, the science-based stuff. He's like, no one else in the economics department takes such high, level difficult courses. But I enjoyed it. I really liked it. I think economics, if you look up the actual definition, is the study of decision making. And I feel like we use decision making every day, where you stop to fill up gas, whether you are going to buy this apple versus that one, or, how you're going to run your practice. It doesn't necessarily have to be all financial, even though the word economics generally people think is something financial. It's a study of decision making. Like, are you going to put a patient on this medicine or that medicine? You're going to try exercise first? Are you going to tell them about the risks, percentage of this or percentage of that? All of that is the study of decision making. And of course, we all believe in the shared decision model of making decisions with your patients. So whether, for whatever the treatment might be. So generally speaking, the decision making, or the study of decision making, is the official definition of it. It kind of fits right in with that. I'm also a certified personal trainer. A lot of people don't know that. So I come from a world of, hey, we're going to lose weight by not eating it, or, working it off. That part is there too. And I also practice obesity medicine. I'm sure you've seen a lot of my posts on helping people lose weight. And I've been doing it since even before we had these new medications that are so effective and so useful, that make it a lot easier. But that's kind of my background. I grew up in Toledo, Ohio, did all my medical school and training in Chicago, and then I moved back to be closer to family.
There's so many things already you said that I want to battle, but we talked beforehand on maybe sort of clearing the air. Just from what you said, here's the things that stood out that I'm like, we should talk about. One is, you talked about decision making and economics. And one of the things that I've prized my career on is, sort of looking at what are the hard outcomes of the medications I recommend, what are the absolute risk reductions, what are the relative risk reductions, and giving people very concrete guidance. If your risk is 10% in 10 years of a cardiac event, and I prescribe aspirin or statin, that'll reduce the risk by, let's say, 1.9% over 10 years, or 0.19% over 1 year, hypothetically, right? I know it's not the greatest way to sort of do it, but it's a chewable, easy way to communicate to patients. And I wonder if you use that approach. The other thing that I want to talk about just give me a second. You said everyone believes in the shared decision making. I don't think that that's true. I think that there's been a big push over the last 5 years to particularly over contentious topics like vaccines, that with mandates that shared decision making is not as valuable as we virtue signaled for 10 years. And then you mentioned the GLP medications. I think we can go right into that as well. But before we do all that, maybe we just hash out on all the things you think we probably agree on, so we can get those sort of out of the way, and the listener could sort of be like, all right, these are the things that they agree on. So, I'd like to come back and tackle those, but what do you think we agree on?
So I think we all agree that people should make lifestyle interventions first and foremost. Now, I'm a cardiologist. I don't always have that advantage, because by the time patients get to me, they're already like had a heart attack, had a stroke. I see them in the cath lab. I put in a pacemaker. Not that a pacemaker, there's anything lifestyle you could do for that. I mean, sometimes, but generally speaking, by the time a patient gets to me, there's a population bias. They've already had multiple heart attacks, strokes, what have you. So from my standpoint, it's not always like, hey, maybe if we eat a little bit less, lose some weight, exercise more, it's going to help, quit smoking, whatever it might be. So from my standpoint, I rarely get patients at a young age where they're like, hey, doc, I don't want to need you when I'm 40 or 50. What do I need to do? That's really rare. That. Well, you probably see patients in the opposite extreme where they're like, hey, doc, I don't want to need anybody when I'm like 40 or 50 years old, because you have a wider net. You guys pick up people that are healthier, a lot healthier and a lot younger. So from my standpoint, they're generally older and have already had multiple cardiac events, and they kind of have to see me now. So from my perspective,
the average age of the patient you see? What's like the average age if you had to?
I'd say probably in the 60s, like for men, 55 to 60, women generally 65 and older, kind of like that whole category. Now we do have some that are like in the 40s and have, horrific genetics. I got some teenagers. I got like a 13 and a 15-year-old that are siblings that have, familial hypercholesterolemia and POTS syndrome and dysautonomia and things like that. We do get some occasional rare ones with the rare conditions, but generally speaking, on average, most of my men are above 50 and most of my women are above 60, which is in line with when people have their first cardiac event, generally speaking. So I think we would probably agree on most of those things, like, lifestyle, eat better, all that stuff.
Walk me through that. So how many, just for the listener, the way we sort of sometimes break up patients is primary prevention, which means trying to get to them before their first event. High risk patients, like you talked about, who have, genetic issues or strong family history, have comorbidities. And then there's another type of patient called secondary prevention, meaning they had an event, they had a stroke or a heart attack, and this is almost a robo referral to cardiologists in the modern medical system. So if you had to break up how much you see primary prevention, how much you see secondary prevention, what would you say, that breakup looks like?
So some of the patients we see, mainly for like blood pressure, cardiovascular risk modifications, clearance for some kind of surgery or something. I don't know that if you want to count all those, like we have blood pressure.
Count all those. Yeah.
Yeah. So those, I'd say it's probably like 30% of all patients. The other 60, maybe 70% are people who've already had an event and kind of are stuck with me forever at this point. But a lot of patients come in and they're like, they got a little high blood pressure, their diabetes is not well controlled. They need clearance for, whatever it might be, dental extractions, or, they have AFib, they have a rhythm problem. Things like that. So I'd say that's
absolutely, we see the reversed. So it's probably like 70%, primary prevention, 30% in that secondary prevention.
Right. Which is probably why there's a lot of difference in our thought process or how we communicate things. Like for me, if a patient comes in, he's had his third stroke, I'm not going to be like, yeah, you're fine, man. Just keep smoking. Right. Or don't take your meds. You'll be great. No. So in your case, a patient comes in, they're younger, they haven't had any issues, and you could tell them things that would prevent them from ever needing me. So I think that's a huge difference with our populations of patients, being someone more in primary versus secondary, I suppose, care. So I think there's a big difference in that for sure. Like, I'd say the amount of teenagers I have is probably a handful. The amount of 20 to 30-year-olds is probably not that much either, but the 40s and up and, people who've already had cardiac events is, probably close to 70% or so, sometimes more, depending on which clinic and which location.
So I'd love to tease apart some populations here. A lot of times when you mentioned FH, which is familial hypercholesterolemia. I think that this is absolutely an area I'd love to focus on, and probably our listeners may not understand what those patients look like. So maybe you can give us an idea of some of those patients that you see, very young, strong family histories, early cardiac events. I certainly would be happy to share some of those patients we see in our clinic. So can you give me an idea of how much of your practice is what you would believe to be a strong family history and genetic factors that lead to early cardiac disease versus diabetes, hypertension, smoking, plus or minus genes?
Yeah, so the familial hypercholesterolemia patients, for people who don't know, these are people genetically born. There's different types of genetics. There's homozygous, which means you inherited both genes or have two genes, two alleles for this disease. Those people usually have their first cardiac event by age 5, maybe 7, usually are most of the time dead by 13 or 20 if not treated at all. There's people who are heterozygous, which only have one of the alleles. They can make it to 25 to 30 before having, or maybe like say 20 before they have their first event. They could easily live to like 35-ish if nothing is ever treated. But generally they're captured eventually by their pediatricians or family doctors or whatever. The rest of the people who don't have so these are people with insanely high cholesterols. These, I've seen 1,000, one person had 998, literally 2 points away from 1,000. Most of the time their LDLs or total cholesterols are in the 300 to 400, maybe 500 range. If these are not caught early, like I said, they have cardiac events, strokes mostly, sometimes heart attacks and PAD, all kinds of stuff by the age 5 up to maybe 13 at the most, for their first event. And then if they're not treated, and luckily we have better therapeutics now that can actually get these people down. In the past, we didn't really. But now that we have therapeutics that can really lower cholesterol levels, these people can live a pretty normal life if caught early enough. That's why if you have the genes for this, it's important to screen kids as low as age 2 if both parents have it. But if not, then by age 8, we recommend kids should get their usual cholesterol screenings, lipoprotein A, whatever. What was the rest of your question? I didn't catch the rest of it. I forget it.
Yeah, no. What percentage are having an MI before the age of 40, have a genetic issue? If you had to give a rough estimate in your clinic, how much?
I'd say the number of patients that have had MIs below 40 is probably 5 to 10% maybe. We do have a lot of men in their 40s, 40, let's say up to maybe 49, 50, that were a combination of bad genetics, bad eating habits, too much smoking, all kinds of stuff. That have their first MI 45, 48, 46. These are generally not familial hypercholesterolemia patients. These are patients that have just had some high cholesterol, which obviously has a baseline genetic characteristics. And on top of it, they did not eat very healthy. They smoked. They made bad decisions. They drank a lot. Whatever it might be. If you combined all of the worst risk factors, no fiber, no exercise, no. And socioeconomically depressed, we have some hospitals in very socioeconomically depressed areas. I'm sure you do in New York. But those patients, when you combine a lot of those things together, make up for a very poor milieu of cardiovascular atherosclerotic disease.
Yeah, I mean, it's interesting. I see a completely different population. And it's. I'd love to share this. I'd love to see sort of how you'd react. So we get a lot of patients who come to us who are concerned about diet-induced elevations in their cholesterol. So we almost uniformly do gene testing, expansive gene testing through GB, if we can get it covered versus, more limited testing through LabCorp.
What kind of testing do you mean in terms of genetics?
Yeah, the GB Health Watch testing. So we'll look at all of the ApoB mutations, LDLR mutations. We will go through
Oh, so you actually
endothelial
look for
function.
mutations. So you don't just go
Correct.
by their cholesterols, ApoB, lipoprotein A, any of that
Yeah,
stuff.
we check all of that certainly, but we also do a full pedigree on every patient. So we are looking for family history of cardiac disease. And I've probably run genes on over 500 patients, a full, I mean, we're talking about 101 cardiovascular genes, including diabetes genes and endothelial dysfunction genes. And I have probably seen a handful, 10 maybe. And again, this is, the people coming to me, this is all selection bias, that are
Sure.
homozygous uh, without any cardiac events.
Yeah,
Homo-
because those people probably already died.
yeah, I mean, yeah, true, absolutely. So this is who I'm seeing in my
I mean,
clinic.
that's survivorship bias too. Those kids are gone.
Absolutely,
Most of the time
absolutely.
they're gone. They didn't make it to you or me.
And the ones who had the highest LDL elevations in my clinic had none of had very rare, possibly an ApoB mutation here and there, very rarely LDLR mutations, almost never PCSK9. And in fact, what we see in our clinic is they have positive mutations on the PCSK receptors that counteract their ApoB heterozygous. So we see these people with wild cholesterol jumps, and we published a case series on this, which you criticized, literally lowering their LDL. I had one patient in there where we had an LDL of 797 that we lowered to 141 without any medication. And we were criticized. And this guy had we ran the genes, no CAC, no plaques on ultrasound, and we were heavily criticized. So, and you criticized me, Dayspring criticized me. So I'm curious, should I put him on a medication? Should I have taken that patient, 797 LDL?
Why was his LDL 797? Just it was diet induced, or
he's very, very lean, that, diet induced, ketogenic. This is basically a phenomenon we're seeing, the so-called LMHR phenomenon, right? As he got leaner and as he intermittent fasted more and as he kept his carbs low, he wasn't very high fat. This is a bodybuilder guy, was fairly high protein. His LDL over the course of 2 years went from 100 to 797, and in the course of a year, it went back down to 100.
How did he lower it? Just change his diet or what?
He just added carbohydrates. So
Yeah, I
he
mean,
added 50 grams of carbohydrates, and the phenomenon reversed. So we thought this was interesting, and we're like, we're going to show the world that the ketogenic crowd is okay with LDL reduction. And we published a case series with 7 patients just like this.
yeah. So Mayo Clinic,
we're going to show them we can lower LDL. So
you absolutely can. I mean,
yeah,
there's no question about that. Diet-induced hypercholesterolemia is what the official technical word for it. Definitely changing your diet will make a huge difference. I don't think that's a new phenomenon. Now, generally, there are these people that have some strange absorption genetics or gene mutations. I don't know what it is or if it's even been elucidated.
yeah,
But
we
there are
looked
some
into
people.
that. Yeah, we looked into the ABCG5 and
Yeah.
ABCG8
Well, that's more
genes.
an absorption
They didn't
genetics.
have them.
Yeah, well, and it may not be absorption because, like you said, they're not really eating that much fat or whatever it might be. But there's got to be some kind of genetics that makes certain people on a ketogenic style diet makes their LDL skyrocket versus others that don't. And for whatever reason, the phenomenon of adding back some carbs seems to help. Now, we have seen the Mayo Clinic went through and did a study on exactly that. They went through their entire database of hundreds of thousands of people. I don't know how many Mayo Clinic has, tons of people, obviously. And they found 17 that fit this exact criteria where they had severe diet-induced hyperlipidemia. Like if you and I eat a bunch of saturated fat, our LDL is going to go up somewhat. It's not going to go to 700, right, or 500. It'll go up a little. But these people, I found
mine will go up to 300. Just I can modulate my LDL
sure,
from.
But it's not going to go to like it's not going to go to like 700-800 or some of these super high levels, right?
I think I could get it there if I get lean enough, to be honest, Alec. I have a cholestech machine in my office, so I'm running these like all the time. I think I could get my LDL up to 500. I think I could, I'm just.
I mean, possible. It depends, I suppose. But they did this scan of all the data on people who had like super high cholesterols that responded to these diets, right? And they found 17 people whose cholesterol went from like 90, or LDL actually specifically, went from 90 to 100, skyrocketed up to 400 or so. And then that was, and they knew their diets. They were like on a baseline diet, went to keto, and then changed it. And they did find that, but they only found 17 people with a 200% increase in their LDL versus the entire database of humans that they've ever treated. So it's not that common. Like I said, most people, if they eat a ketogenic diet, it depends on so many things. Like you could technically do keto without eating saturated fat, right? You could use other types of fats, poly and mono unsaturated, what have you. It's not going to make as much of a difference. If you do eat mostly saturated fat, yeah, you're going to have quite a rise in your LDL. Maybe not to those levels, not this 700-800 level, but like you said, maybe some people are able to do that. And, we'd have to run a huge study on that. I mean, there have been studies, like you said, Mayo Clinic did one. They found like 17 people that had that huge of a rise or that big of a jump in their LDLs. But at the end of the day, like you said, if they modify their diet, cut back some of these things or add some things, it seems to go down. Now, still at 140, that's quite high. Now they recommend that all comers be under 100 for LDL at least, and total to be under 150. Just based on the cholesterol years data and the likelihood of having an MI or stroke or atherosclerosis or what have you, 1 or 2 years isn't going to do it. You get a guy in here that gets their LDL up for a couple of years, probably not going to make a difference. Maybe even 5 years, not going to make a huge difference. But if they stay like that for a few decades, it's obviously going to be a big problem. Depending on other factors, of course, if they're smokers, it obviously is worse and whatnot, diabetes, obesity, whatever.
I think that's a great segue to lifelong lowering of lipids, because I think that this is an area of contention. I wouldn't say that. I'd say probably 80% of cardiologists would completely agree with you, and they believe that lifelong lipid lowering is probably a beneficial thing. I think that there's a subtle movement in cardiology, particularly in the cardiovascular imaging sort of circles, that are saying, hey, wait a second, there's a power to screening for disease and maybe not over relying on LDL or ApoB as the marker that should drive this in treatment decisions. And maybe instead it should be the presence of disease, whether it's from an ultrasound of a femoral artery, the ultrasound of a carotid artery, that's the PISA study suggested, or using CAC or CCTA in primary prevention. So what are your thoughts?
So this is a really good question. I think visually it would make more sense if I showed you a arterial model, right? And your listeners, I mean, you and I understand this, but listeners may or may not. So I don't know if you post these videos or just audio, but this is what a artery looks like. This is obviously normal. The lumen is wide open. There's nothing going on. Most of us hopefully are somewhere in this range. As disease progresses, the lumen stays open. The artery remodels outward to try to keep the lumen as open as possible. Eventually, late stage disease, you finally get some narrowing of the lumen. You don't see calcium till you're somewhere in this range. And, if you have it, or you have it mostly in late stage or end stage atherosclerosis, and that's a problem. If we're waiting, I always tell people it's kind of like telling smokers it's okay to keep smoking until like finally at age 50, we detect lung cancer on a CT, or 60, whatever it might be. You don't want to tell people, keep smoking. Oh, we did a CT, you're fine. And then finally at age 65, like, oh, you got a nodule. That's a huge problem. The other problem with CCTA, it's kind of the same thing. Like, I read these studies for a living. I even do angiograms of people's arteries, with cardiac caths. We inject dye in here. right? And this is what you see. You don't see this. You don't see this. Like people could have soft plaque building up in their arteries and it's remodeling outwards and this looks wide open. So the problem is until it gets like so far gone that it starts narrowing, it's going to look normal. And that's a problem. You're waiting to finally see a huge problem. And then it's like, oh, now we have a problem. Now let's treat it. I'm a preventative cardiologist. I would rather you never have this problem. Imagine like you're huge on diabetes, right? Imagine if patients came to you and were like, look, I know I'm starting to get a little insulin resistant, however you want to measure that. What should I do? And you tell them, do this, do that, do all these things. You don't want to wait till their A1C is like 7.8 and they're like, oh, now I'm really insulin resistant or 11.2, whatever it might be. Now I'm like super diabetic and I got to be on all these meds and lose weight and change my diet and do all this stuff. You want to catch these people way before, because like with diabetes, you could generally reverse it, get it down enough so it's under better control and maybe not be on meds or just on one maybe. But with atherosclerosis, if we let that go too far, your chances of reversing it is not very high. Plaque, when somebody has an occlusion or like, occlusive atherosclerosis, there's almost no way to reverse it. You can stop it from getting worse. Now, some of the new data with like super potent drugs like Repatha and whatnot with the Glagov study and a few others have shown like a little bit of regression or overall global plaque volume goes down slightly, but we're not talking like a lesion that's like 78% is going to drop to like 30. It's just not going to happen. It might go from 75% to like maybe 72, maybe 70. It becomes more fibrous. It becomes thicker, so it's less likely to rupture. But you're generally not going to take somebody with a very advanced disease and reverse it all the way out. It just doesn't happen, at least not with atherosclerosis. So waiting till there's a calcium that is positive and waiting until there's a coronary CT angiogram or a cardiac catheterization that is positive or abnormal showing plaque is like waiting way too long. And we know that since the problem starts with lifelong exposure to high LDL or high ApoB, why not attack it decades before it happens instead of waiting? That's like imagine you had genetic markers, you do your genetic testing on a patient and like for sure they're going to be diabetic by age, let's say 50. Why not tell them, hey, listen, you're going to be diabetic for sure. Why don't we attack this from now? Why don't you drop 20 pounds? Why don't you start exercising? Why don't you start, doing this? You don't want to wait till they're, so far gone that a lot of the damage is done and it's irreversible at that point.
So I think I want the very interesting comments. I agree with a lot of what you said, but I want to come back to the comment about the CCTA and the carotid ultrasound. And the femoral artery ultrasound. The PISA study suggested that you can detect some soft plaques before a positive
with ultrasound.
CAC.
Yes.
Yeah. So you can combine. So I think in my clinic, we do ultrasounds on nearly everybody, both femoral artery and carotid. We review beyond what the radiologist says because, as they don't comment unless it's under 50%. Yeah, correct. And we're also adding TIMT on those. So the thing is we can detect. It's very easy to detect, and it's low cost. And honestly, I believe we should be training every internal medicine doctor and family medicine doctor on how to do these. So they can guide
ultrasound,
better.
absolutely.
So now if you take these two and you have the absence of disease in these two cases, no ultrasound evidence, IMT not elevated, and CAC, 0 or CCTA without any disease, should I consider a medication in a case like that with an LDL that's somewhere between 100 and 190, 189?
So that is where maybe something like that would come in useful. If you have an ultrasound of like somebody's carotid and it shows there's like some mild plaquing or like the carotid bulb looks like there might be something there, and then absolutely, they already have imaging evidence of atherosclerosis. Absolutely. If you image their carotids and it looks like completely fine, that's where you got to have some kind of cutoff. I wouldn't go as high as 190. I would say, if they're like 110, 115, I'd probably be like, we can wait. But if they're like above 130, like the PISA trial above 130, I think it was like 54% of people had atherosclerosis in at least 2 arterial beds. So I think it depends on the person, like, you know them, you like talk to them, what's your family history? Do you smoke? Are you obese? Do you have diabetes? Do you have all these other things that would make a difference or not? If they're like, no, I'm totally fine. I don't smoke. I run marathons. I got great family history. Nobody they all lived to 90. Nobody has heart disease. Okay. That might be a different story. But generally I'd say, like the official guidelines are over 100. You need to get it under 100. However you do that, you can change your diet. You can eat more fiber, like whatever you want to do. Or if you're not willing to do that, or let's say you did all that and it's not coming down still, then generally speaking, you got to be on something to get it down. Now that's something, there's a lot of options, but generally a very low dose statin like Crestor is super potent and will probably drop you into the 70s if you took just 5 milligrams and you were like right around 100, let's say like 110, 120. But again, like if there's absolutely no evidence of anything, yeah, then that's a conversation. But I would not let somebody be like 150 and higher. It was 68% of people in the PISA trial. If their LDL was over 150, 68% of people had atherosclerosis, had plaque somewhere in one of their arterial beds. And of all of the people that showed plaque somewhere, 63% had it in multiple arterial beds. So I don't know that I would wait because some of them are not detectable. Like carotid's easy to access. And also they use a little bit fancier imaging. They use 3D IVUS, their 3D ultrasound. They used spectroscopy, MRI, things like that. So the kind of imaging that we have, like the two mode, whatever it's called, the grayscale and the two mode, the M mode ultrasounds that we use generally isn't as fancy as what they have in research labs. So there is a chance of missing some things, especially in the arterial walls. And don't forget the carotids and the femorals are huge arteries compared to coronaries. Coronaries are like 2.5 to 4 millimeters in the lumen, whereas some of these are 7, 8, 10. The femoral is like probably close to 15, 20 maybe. So you're looking at like different types of arterial beds. So yeah, that's a conversation to have with those patients. Your patient population is obviously healthier than mine, so that is definitely a conversation where we say, hey, listen, the statistics say X, Y, and Z. It's up to you, but here's what I would recommend. And then obviously they get to pick what they want.
One of the issues I have with being, and this is an issue I have with the guidelines. It's not just, what you're saying here is, if you have a 0 CAC, there's very little evidence that, you're going to need multiple years of treatment, maybe even 10 years of treatment of, lipid lowering treatment to experience any benefit. I mean, it's certainly more than 10 years. I think that's what the Power Zero study showed. And that's what the Power of Zero studies are continuing to show.
I mean, I'm not going to get into the Power of Zero study because we can talk about it off the air, but there's lots of, let's just say, conflicts of interest going on with some of these studies. But
can you explain them to me? Because I don't know.
I mean,
so.
I'm not going to say anything. We can talk about it later.
I mean, I don't know. Do people make money off of $100 tests? Like that I'm not aware of. I just help me understand.
I mean, I think there's first of all, I think like some of these people don't actually read the imaging, or they're getting let's just say hefty grants from the CT scan makers and whatnot. But either way, like with all that said, let's just look at the data and the science of it. It's just not. Like we've had those around, like Dr. Agaston. You probably know Dr. Agaston. He's from Miami. He invented the South Beach diet. He's a cardiologist from Miami. He invented this back in like late 90s. The calcium score. No one has ever used it for like 40 years because like it's almost useless. Like me personally, I don't order them. We do get patients that go get them done and they come to me. We do the CCTAs. Personally, I don't like to order.
It's useless for you because a lot of secondary patients, a lot of secondary disease and high risk patients are coming to you, right? So
they've already had disease.
For you,
Yeah, for the most part. But if I get like a 40-year-old that's like, doc, I don't know, my risk, whatever, I'm like, I mean, you can go get that test if you want to. No insurance pays for it for the longest time, obviously, because it wasn't in the guidelines. And technically now it's in the guidelines. It's in the guidelines now, 2019. They added it, but it's for patients who want to refuse medications and maybe want some imaging, which is fine. I agree with that. If there's like a patient's like, I don't want to take anything, doc, I'm good. And then you do a CCTA. Like I said, it's like looking for lung cancer and a smoker doesn't want to quit smoking. And then you mentioned something about time to benefit of statins. I'll give the example of like a smoker. If you have like a lifelong smoker that comes to you and is like, doc, I quit smoking for 2 months, but I've been smoking for 40 years. Do you think that's going to add any more lifetime to my years or, cancer free because I quit for 2 months? Maybe. Probably not a lot. It's kind of like when these people say, well, somebody's been on statins for like a year, in like one of these studies, it was like 13 months, how much time, how much more, event free are they going to add to their life? I mean, maybe a week, like probably nothing, because it's like the area under the curve has to accumulate. You put somebody in a trial for a year or two and then say, oh, yeah, this only did this. Well, sure. I mean, that's like, telling a smoker just quit for a few weeks and see if you live longer. Like, that's just insane.
I don't love the idea of looking at LDL, like some harmful particle. There are, it is absolutely used in sepsis, like it's an acute phase reactant. The more severe an MI, sort of uses up LDL. Infections use up cholesterol. I mean, if you want to see LDL drop, just take somebody with severe sepsis and check their LDL before and after. So right. I think like looking at LDL as some harmful thing, I understand it's implicated in cardiovascular disease fairly well, but I don't know that I would compare it to smoking. I mean, smoking is, I can't understand one. I mean, maybe you could argue that it increases testosterone, nicotine, or something like that. But, I don't love the comparison to smoking for LDL. I think, if you have cardiovascular risk, it may be something that you want to pay attention to.
So you're right. First of all, LDL is for most of its lifespan, like people say, well, LDL is bad for you. Well, it's not always bad, because there's a huge part of an LDL particle's lifespan where it's getting rid of cholesterol, like an HDL molecule. And I'll just show you these because sometimes people are visual. This is let's say this is
we got LDL. Mostly listeners, but that's fine. So you got to describe what you're seeing. Yeah. We got so 50,000 per episode will listen to this. So you got to describe what you're seeing.
We'll describe it visually. Imagine a tennis ball, right? It is a low density lipoprotein. Inside of it is a yellow, fat, waxy substance called cholesterol. There's another tennis ball, let's say a red one, that comes up to it that is an HDL particle. The HDL gives its cholesterol that it collected from arteries to an LDL, and the LDL returns it to the liver for elimination. Like the HDLs, there's more of them. There's 27 more times HDLs than there are LDLs, and they go to arteries and collect cholesterol out and give it to the LDLs. As a part of their lifespan. Like HDLs do go back to the liver and eliminate it too, but they don't fit as much. They're tiny little things. So they give a lot of their cholesterol to LDLs. LDLs exchange those for triglycerides. They give the triglycerides to the HDLs in a process called CETP, cholesterol ester transfer protein, which is like a new target of therapy that they're trying to see if that helps. But they give
which it historically failed, right?
Yeah, absolutely. Yeah. Historically has absolutely failed. 4 different types they've tried. There's a new one that seems to have some benefit. We'll see, I guess. I'm not one of these people that just jumps on the latest and greatest drug. Like, you better show me some serious benefit. Like, why am I going to be prescribing a new medication that costs a ton to my patients? It's not generic when I have generic alternatives that work really well, or actually cause benefit. Like one of these drugs is Multec. I don't know if you haven't ever seen Multec. It's like an antiarrhythmic that does absolutely nothing.
Right, or not amiodarone, the cousin.
It's like amiodarone. Yeah, dronedarone. It is like amiodarone, but has zero benefit. We don't work
for the pharma companies here, so we use the generic names.
Yeah, same here. Every time if we have a generic option, we use that, because first of all, Multec is useless. Second of all, it's like $3,000. No insurance will pay for it because it does nothing. So either way, but that's we got off sidetracked a little bit. But either way, LDL particles for a significant period of their life help return cholesterol that was picked up in arteries and various tissues that are not needed, to return it to the liver to then be excreted and eliminated via, bile acids and whatnot into your intestines. But there's no doubt that when LDL particles are over a certain concentration gradient, they got nowhere to go. If they're really high, you actually see them in your eyelids and, your corneas, even in your tendons, various body parts, especially like these kids we talked about, familial hypercholesterolemia. But in normal people without FH, you see it in your arteries, plaque buildup, all of that, and you don't need a lot of LDL. Like, they've done studies where people's LDLs are down into the like, below 10, below 15, below 20, and there was no adverse effects from it. All they saw was less coronary events, less major adverse coronary or cardiovascular events, less strokes, less heart attacks, peripheral artery disease, those kind of things. So I feel like the comparison to smoking or any other risk factor, pick one, I don't know. Let's say you have insulin and diabetes is super uncontrolled. You don't care. You're not doing anything about it. You're not losing weight. You're not taking meds, whatever it might be. And you just let it go. That is obviously a huge problem. It's very similar with high LDL. You're just if you're just letting it go, that's going to develop. And the piece of trials that you keep mentioning is a great study because it was young people. The average age, the median age was like 42. They less than 10% of them had a calcium score that was above zero. None of them, like less than 18%, were smokers. They were, young, healthy, low BMI, generally healthy population of people in their 40s, essentially, that had nothing else other than high LDLs. And if your LDL was above 150, you had like almost a 70% chance of having, one of your arterial beds, if not two. With plaque, if it was 130, it was 54%. If it was 110 even, it was 45%. So definitely we know that even in otherwise healthy people, high LDL by itself does cause atherosclerosis. And that's the reason why we're super aggressive about it. We want it to be lower so that people never end up with this. And waiting to get all this testing that is more late stage testing is definitely a problem.
So I agree with you on early stage testing, and the Women's Health Initiative, showed the amazing utility of looking at an LPIR score to predict, cardiovascular disease, right? And insulin resistance, remnant cholesterol, which is absolutely a marker of insulin resistance. So when we're looking at early stage disease, here's the dichotomy, right? I focus almost completely on early stage disease. And those are the markers that I care about because I feel like they're much more predictive of developing coronary disease. I think that the use of the imaging, you're right, it's a bit late, but it can help me risk stratify on who I should consider pharmacotherapy, consider that recommendation or not. But I want to come back to the power of zero because, you go to this patient who's, let's say, 45 to 55 years old, has some risk factors, but they're invested in lifestyle and they don't want to use a medication. And you find you risk stratify them. They're zero CAC, they have no, signs of plaque and they don't want it, right? So coming back to shared decision making, I think
if they don't want it, they don't want it.
I think it's very completely reasonable to say, well, this is the point of that Power of Zero study. I think what it gave me as a clinician is knowing that, hey, look, if I put you on this medication right now, I may not see the benefit for 10 years or more. How do you feel about that?
The issue becomes then if one of these plaques, so first of all, 80% of heart attacks are soft plaque ruptures. I mean, none of these are like calcified lesions because calcified lesions are stable. Imagine like if you imagine you have a jelly donut and you squeeze it and all this stuff oozes out into your artery and plugs it up. If you take that jelly donut and dip it in some concrete and wait a few days till it hardens, you squeeze it all you want, nothing's going to happen. I mean, calcified arteries are hard. Nothing's going to happen. Like they're super stable. Over time, as they get narrower and narrower, you will start to have exertional shortness of breath. Like when you exert yourself, you get out of breath, or you might get some chest pain when you exert yourself, but they're not going to rupture and give you a heart attack or stroke. Now, the soft plaque that comes along with it, because if you have hard plaque, you have soft plaque. The soft plaque may rupture. And the problem is it happens decades before. So and I agree with you. If a patient says, listen, I don't want to take anything, fine, no big deal. Or you don't have to take it. I have plenty of patients. I had a guy who had 3 strokes and was like, I don't want to take meds, doc. Okay, no problem. We talked about it and I told him, listen, the chance of you having another stroke is pretty high. You've had 3 already. He's like, yeah. And he still wants to smoke and he still wants to do all that stuff, just as an example. So we can't force people to do things. We give them all the information like, here's what's probably going to happen. And this is up to you. You want to take meds, take meds. You don't want to, it's up to you.
Well, so let's walk through that 45 to 55-year-old patient. Maybe they have hypertension. Maybe they want to, and they have a zero CAC. What is their benefit from, and they have an LDL you're not comfortable with. It's 130, it's 150, it's 170, it's 189, whatever it is. When you give them the statin, they're like, doc, just tell me what this is going to do to me. Like, what is this? What is the actual effect on me? Like, how much, what's the chances it's going to save my life? Like, how do you present that? And maybe we can compare how I would present that.
So look, I mean, I would sit down and have a conversation with them, and we do this obviously every day. So you do too as well. You say, listen, these medications have been shown over time. First of all, they're generic and cheap. This ain't going to cost you money. I get nothing out of it. I don't like people think I get a paycheck every month for prescribing statins, which literally costs like 2 pennies for an entire 90-day supply, maybe. They're super cheap and cost. And the only one that isn't is pitavastatin. Nobody uses it. It's not that potent. Pravastatin is similar in potency. Maybe it's like a touch more potent than pravastatin, but no one's going to prescribe a medication $300 a month when like something that costs 2 pennies or like $3 copay, 0 copays is going to be more than enough. So we'll have that conversation. We'll say, listen, here's the data. You're 45 years old. I don't use these 10-year risk calculators and these 30-year risk calculators. I mean, I think those are great for people who don't do this every day. But for me, like, I know my patients, like, all right, you're 45, you're not a smoker, you have this kind of family history, that kind of family history, whatever. Like in my mind, I kind of already know what their risks of an event are. I think those kind of risk calculators are great for, primary care or these like, electronic medical record systems that pop up a risk for you while you're seeing the patient. Like, hey, by the way, your patient's risk is 12%. Just as a reminder, kind of like how they remind me to do colonoscopies on patients every time, which I don't do. My dad does, but not me. But, they pop up with all these reminders to kind of keep the, dangerous drivers off the road. Like if you're a family doctor or an NP or something, and you forget to do a colonoscopy on a patient by a certain time or screen for mammograms or whatever it might be, those are good reminders. But for me, who does this like every day for a living, I'm not going to use these calculators at all. Like in my mind, I do the calculations and I sit down with the patient and say, hey, listen, your chance of having a cardiac event with your kind of numbers are XYZ. And
let's do it. Let's, this is not medical advice for the listener. I'm just going to use my own example. I'm 45, I have an LDL of, 179, and I have a grandfather who died at the age of 43 from a heart attack. I have a 0 CAC. My carotids are completely clear. This is not medical advice. This is a hypothetical question. And I have no insulin resistance. I have a completely normal A1C. My blood pressure is 110. What's my risk of dying in the next 10 years from a cardiac event?
I don't know what your risk of dying is. Because,
from a cardiac event. Yeah.
Having a cardiac event, probably quite high with that LDL of like 180. I mean, how long has it been 180? I think it depends.
Maybe my whole life. I don't know. Who knows?
Well, I mean, you got to give me like a number. I can't. I mean, if you want to do like a specific patient, was it ever like 60 or 70 for a long time, and now it's 180?
The earliest I can make it fluctuate from 90 to 300. Depending on what I include in my diet. So
we use this thing now called like cholesterol years or milligram years. So if you take your age, let's say, I'm going to make up a number here because
say the average is 150. Easy. Say the average.
Well, just to do the math to make it easier, let's say you're only 40, right? And your LDL is 125. You multiply 125 by 40, that's 5,000, right? Above 5,000, we know for certain almost everybody has plaque, whether it's soft or calcified or, a combination of both. We know that. Above 2,000, we know that most people probably have some soft plaque, and as you get to 5,000 and higher, it, more and more soft. And then eventually, if you had it long enough, it'll necrose and crystallize and it'll become calcified. We know that most people from various trials with a 60 milligrams, above 60 milligrams per deciliter, or like 57, if you want to be specific, but let's just say 60, above 60 milligrams per deciliter, most people are putting down plaque. Now you multiply that by years. So a patient that comes to me in your exact scenario with an LDL of 170, let's say 45 years old, none of those risk factors are things that you had, I'd say, look, if I were you, I would probably be on something or change my diet if you think it's mostly diet induced.
What's the benefit to me? So I'm going to consider your rosuvastatin, your generic rosuvastatin. what's my benefit? Tell me my benefit. I
The
want to
benefit is
know.
you can keep living the way you are, how you're eating. I suppose if you don't want to change your
No,
diet,
I'm a
you can keep.
numbers guy, man. I'm an economics major. Give me like, I want to know what's my risk? What's this
So
drug going
your
to do
risk of
for
having
me?
a cardiac event over the next 10 to 20 years is almost absolutely certain. The question becomes like, do you want to make that go away or not? I mean, it's almost certain that you will. I mean, like, like I said, you're basically the patients in the PISA trial. No calcium, 45, healthy, young, no insulin resistance, BMI semi-normal, up to like 25, I think, or 24 point, whatever it was in the trial. You're that patient with an LDL over 150, 68% had atherosclerosis somewhere. So you're kind of in that range.
So I
And it's
will
up to
have an
you.
event in the next 10 years, like
And you
100%,
said your
100%
father had
risk.
one in 45 or 43. I
Grandfather.
mean,
Yeah, yeah, yeah.
yeah. So I mean, that's the genetics is not on your side,
Yeah,
uh,
yeah.
in terms of just
I'm
family
just,
history.
so it's 100. So you're in your mind, the way you process this is 100% risk of
I wouldn't say 100
cardiovascular.
because you never know,
Yeah.
let's say 90 and above, somewhere in that range.
So my risk is 90%. And then
In the next
service.
20 years, almost certain 90% or higher,
Got it.
something bad will happen. And
And
we don't
so,
want you to, but
so what would be, so if my risk is 90%, what will the statin give me? What will
so if we
the
get your LDL down, and it all depends on how long it's been high, right? So if it's been high for just a couple of
20
years,
years, well, everybody's cholesterol starts to rise at 20, right? So,
right. It
okay.
depends on how much, but so let's say you've had 10 to 15 years of pretty elevated LDL. Generally, we could probably reduce your risk down. So the fact that you don't have any chest pain when you exert yourself or when you exercise, I don't know if you run marathons or I don't know what kind of exercise you do, but let's say you run a mile a day and you don't feel anything, right? You're not short of breath. You're not getting weird chest pain. That's good. That means you don't have occlusive CAD. That means you don't have any lesions above 50 or 60%. We could halt that there by getting your LDL down into a normal range. Mine is 41, 44. And we know below 55, generally below 57, you arrest atherosclerosis. Unless you have lipoprotein A, that's a different story. But I'm assuming you've checked that on yourself for this fictitious patient.
correct. Yes.
So
But
if you don't have
zero.
lipoprotein A, you're probably, and if you get under 60, you'll probably be fine.
So help me understand. So I have a 90% risk, and then what is my risk reduction? What is my relative risk reduction and absolute risk reduction? I have a 90% in the next 20 years of having a coronary event. Walk me through with what you think the benefit would be for me to take Crestor 5, 10, 20 milligrams, 40 milligrams. And let's say you knew 10 milligrams of Crestor would lower my cholesterol to 70, right? So what benefit am I getting roughly?
So if we get you under 60, let's say, we put you on probably 20 of Crestor, 5 of Zetia, and maybe Repatha plus or minus, I don't know. We could probably get you down into the 30 to 50 range if we did all three. It just depends on how well you respond to those two medications. I don't know. Most people with a little bit of Crestor and Zetia drop 55, maybe 65%, just kind of depends on the person and the dose of the Crestor.
So what's the benefit to me?
So the benefit to you is we could make sure you don't have a cardiac event.
What's the percent? Like it's got, it's not going to prevent, uniformly prevent. I mean, people.
So I don't know with you. I don't know with you because we don't have
the 90% 20-year risk. So 90% 20-year risk is sort of what you gave me. So I want to understand.
So look, we know that if we drop people's LDLs to as close to below, 55, 40 even, that there's not going to be any atherosclerotic events. I mean, the Jupiter trial, for example, took older people with LDLs in their 70s even and put them on Crestor 20s, that rosuvastatin 20. People below 57 had no further atherosclerotic events, if any. And we know based on multiple studies, however you want to measure it, randomized control trials, cohort trials, Mendelian randomization, whatever you want to look at, we know that below 60, the chance of atherosclerotic events is pretty close to zero. I mean, we're not going to say it's zero because there's always somebody with some weird, mutations or genetics. I don't know. But we could probably drop that 90% to probably you're never going to have a cardiac event ever. But obviously there's people with strange genetics and something might happen. I don't know. You said your grandpa had something, so I don't really know what his story was, but there might be something there.
help me understand the error in my thinking. So I'm going to take your 90%. We'll just assume that that's accurate. The way I would communicate that to patients is the strongest meta-analysis data for statins, including primary and secondary, which I may fall in between, would be a 20% relative risk reduction, right? So that would be looking at 90% over the next 20 years.
So it's a 23 to 26% relative risk reduction for every 1 millimole of LDL lowering, which is like 38.
So we're talking apples and oranges. You're doing meta-analysis, sort of a look at LDL lowering and the cumulative effect that's calculated over a number of trials. I'm looking strictly at the Crestor that you recommended to me. So me adopting Crestor for primary, secondary prevention lumped together has a relative.
So Crestor by itself dropped MACE 44% in men, 46% in women. So
the meta-analysis from JAMA Internal Medicine, that was probably maybe published 2 years ago, which I think was the most comprehensive meta-analysis I've seen recently. It quoted the number of 19%. I'm just going to say 20%. So if we cut the difference 20 and 40, let's say 30%. So my personal benefit over the next 20 years would be that I would get a 27% lowering of my chance of having a heart attack.
Right? I mean, it depends on how low we get your LDL, to be honest. Like if you reduce, so it depends on, like, we know for every 38 milligrams per deciliter lowering LDL, and this is just in general, like if you look across all trials, whether it was statins or, whatever, if you reduce your LDL by 38 milligrams per deciliter, let's just say 35 or 40, whatever you want to, something even.
Let's say 70. Let's say you lowered my, we'll pick 70.
Yeah. So that would be, that's like a 26% reduction for every 35. So you drop it by 70, you get down to 100, let's say, you would reduce your risk 50%, in that case. Now this is also like, don't forget there's like a cumulative effect. You're just talking, you'd have to be on this, probably indefinitely at this point, unless you change your diet around or do some other things. But there is a cumulative effect where the area under the curve, increases over time, and the Kaplan-Meier curves, the survival rates in the group that is on meds would be more. Now, obviously, everybody's going to die of something. So, we don't think with modern therapeutics, we think that we could have more people living into their 90s, and healthy 90s, not like, decrepit and can't get out of bed and can't deadlift or whatever, but like we think now when you talk to some of these, longevity experts that you're not going to live to 150, but some people might, they say like people could technically live to 140. But what's going to happen is because of, especially now that we can reduce the burden of chronic disease with some of these new GLP medications, if we can reduce obesity rates so significantly, so, lifespans have gone up despite, higher burden of chronic disease. If we can eliminate the burden of chronic disease, we can probably increase lifespans, even further. So if we get rid of obesity and some of these things, which naturally will reduce hypertension and sleep apnea and cardiac arrhythmias that associate with that, and insulin resistance, all that stuff, if we were able to reduce all that and lower people's LDLs and all of that, we could have more people living into their 90s at a good lifestyle, good health span, more functional, able to do a lot more. So I don't know, like there's always data and math that we can try to calculate out these things, but then there's also, let's we know.
I think we should, and I'm gonna go to a trial that I know you know. So the Accord trial, you remember the Accord trial, which was looking at intensive diabetes management.
For diabetes, yeah.
For diabetes, I think
Advance was around the same time.
Yeah, I think if they redid that trial now with some new drugs, they would come to a different conclusion. But let's just take that trial as face value, right? So if I was an endocrinologist and I simply looked at the A1C and tried to lower people's A1C using more and more aggressive therapies, right? A1C is a risk factor, blood sugar is a risk factor, right? And I aggressively lowered people's blood sugar. What ended up happening, which was antithesis to what most people thought, is more people died. Now that more
Yeah,
people
they had
dying
heart
is
attacks because they had hypoglycemia reactions, and they released tons of catecholamines and epinephrine and all that, and they ended up with
100
MIs.
percent. Look, I think it can be absolutely the biggest cause of mortality that was different in that study kind of was related to aggressively lowering medications, particularly in the elderly, and causing hypoglycemia and
Right. It
cardiac
was the
events.
elderly patients that they tried to get way too low.
Also, maybe Actos, at the time, which has been linked to
Actos
cardiac
definitely
events,
causes heart failure, or
right?
for in certain
So,
populations.
so when we take a sort of idea that makes sense, which is let's reduce a known risk factor, right? And blood sugar is a very well-known risk factor. It's probably the most significant risk factor for heart disease. Presence of diabetes is probably the single most predictive factor for predicting a cardiac event. And you do what seems to be like a good idea, and probably I bet, and I'm going to even caveat this. I bet if they did that study right now with SGLT2 inhibitors and GLP-1 drugs, we would have a different conclusion.
Right, because
But
they don't cause hypoglycemia.
right, and they also have had mortality benefit and decreased MACE. So, but my point is I think there's a trap when we don't force the drug companies to show a mortality benefit with their medications, right? And when we pursue endpoints, and when we take an approach that looks at surrogate markers as a therapeutic standard, instead of just looking at the benefit of the medication and using the underlying risk and the benefit of the medication or the class of medication, right, rather than extrapolating that out to some line that an actuary drew with all the medications and all their effects on LDL. So let me make this a little more simply. I think where I disagree with you is the fact that you're using LDL reduction as a marker that causes that would imply risk reduction. And I don't do that. And I would caution against it. What I would do is look at the individual drugs and use their risk reduction, because if we extrapolate and put into the mix a surrogate marker like an LDL level, we may not get the results that we intend. So what do you think? Do you think my way of thinking is incorrect? Is there a flaw in my thinking?
No, I think that's generally true. We have to show all kinds of benefits when we do trials on medications. Absolutely, they need to show event rates reductions, mortality benefits, cardiovascular mortality, all-cause mortality, which they do. I mean, statin medications.
Statins are the only class that do, right? So statins are the only class of lipid-lowering medications that have shown an all-cause mortality reduction.
Yeah, absolutely, because showing all-cause takes time. Like, you have to follow people for a long time. The other medications have not been out, like bempedoic acid, Nexletol, is very recent. There was the clear outcomes trial data, and like for Zetia, it was, I forget the name of it, forget the name of the trial, but they eventually will eventually be able to elucidate that as time goes on, because we'll have more data. Statins have been shown in, huge meta-analysis. When you don't exclude any studies and you include every study that's ever been done on statins, it was 26 of them. So far, the biggest meta-analysis ever done on this, they did show an overall reduction in all-cause mortality. But there was an interesting article that I'd be happy to send you that said, we should not be chasing all-cause mortality in cardiovascular therapeutic outcome trials, or any outcome trials for a specific cause. Like, if we're looking at a medication that reduces cholesterol, let's say, or blood pressure, there's no reason to be looking at do people have less pneumonia, or do people die of car accidents or gunshot wounds? I mean, that's just kind of insane that we're chasing all-cause mortality when the drug or the therapeutic agent is designed to lower blood pressure or reduce, whatever it might be.
I think I would disagree with you here, and maybe this is a point of disagreement. I think we should pursue all-cause mortality so we can more reliably say, hey, this medication can save your life. And I think asking the drug companies to do this, let's talk about the PCSK9 inhibitors and Zetia. I like Zetia. It's a fairly benign drug. Ezetimibe, prevents cholesterol absorption. It's been shown to reduce cardiovascular mortality in clinical trials. It's never been shown to reduce all-cause mortality. But the PCSK9 inhibitors, which have the most potent LDL lowering, even like 10 times as potent as Zetia,
Right.
they had 10,000 people in a trial for 7 years. We're talking about Odyssey and
Warrior.
Courier, right? And it didn't even show a cardiovascular mortality reduction. They had to, string together unstable angina and this and that, right, to get a benefit. So I have a hard time recommending drugs, and tell me if I'm wrong, that don't have hard endpoints. Right, statins are a little bit easier, even though statins are dirty drugs, in my opinion. They cause muscle aches. They reliably,
Well, the newer
cause
ones are more synthetic
diabetes.
and
Right,
cleaner.
right. They cause diabetes,
Well, they don't
but
cause diabetes.
they
And this
raise
is a
blood sugar for sure.
they could, like the Jupiter trial
But
was the first time we noticed this. But just so your listeners know, because I don't want people thinking that statins actually cause diabetes. For people who had diabetes or were on the cusp of having diabetes, like they already have insulin resistance, however you want to measure it. These people in the Jupiter trial had a A1C of 5.8, which is definitely not normal. And the people on statin went up to 5.9, which is a 0.1% increase. And even forget that trial. That's really old trial.
well, the
They've
Lancet
done,
study,
what's
6 months ago, Lancet
yeah, there's a
study
new
from the
study. Absolutely. There's
yeah.
a new study that looked at 7 million, person years of follow-up. There's another one with 5 million years, 5.4 million years of follow-up, more recently looking at atorvastatin versus rosuvastatin and the higher dose of this and that. They found that people who were on the more potent statins or more, whatever statins had a 7% more like increase in either initiation of diabetes meds or strengthening intensification of medications. But these were people that were already diabetic. These were not people that were non-diabetics that suddenly became diabetic. These were people at or near the threshold of diabetes.
Look, most people going on these drugs have insulin resistance and are at the
Not
threshold of
always.
needing.
I mean, it's not a high percentage. I mean, maybe in your population is different, but in like from what we see, the majority of people who have heart attacks, only 25% of them have diabetes. So it is the other 70 to 80% don't. So I don't
Or
think that it.
pre-diabetes, right? That's
Well,
probably
even if you counted pre-diabetes, 15 to 35, maybe 38% of the population, depending on what study you want to look at, has insulin resistance that's not yet been diagnosed as diabetic. 9.3% has type 2 diabetes, like outright. So that's not, and that's not the majority of people that are having heart attacks. The majority of people having heart attacks are just people having heart attacks. When they went back and looked at data of who was hospitalized with an MI, 20 to 25% had, outright diabetes.
I mean, that's
Still,
not those types of data are a little inaccurate, right? It's like, people hospitalized with MIs have a low LDL. It's not
right. And there's
it's
reasons
not,
for it, obviously.
it's not a great way. But like, let's come back to the statins, and I'll give you my opinion and maybe you can criticize it. I don't like, I think statins are both the best drug in the class of all lipid lowering drugs and also simultaneously the worst drug in the class. Right. And I'll give you my reasoning. Much
Why do
more
you feel they're
likely.
also the worst?
Yeah. So I feel like there is all-cause mortality benefit. The HPS study, the CAS study. There is all-cause mortality benefit, which makes it the most likely to be effective. Right. We can say most concretely that if you are at high risk and you want to lower that risk, this is the most likely to be effective. They're also the most likely to cause side effects, myalgias, liver
Yeah,
issues, and
absolutely.
worsen insulin resistance, decrease in sort of the mitochondrial function. People feel lousy on them. Certainly you can titrate the dose and, you may be able to, supplement the CoQ10 and, plus or minus or K2 that's depleted. But my point is people don't like it. People don't feel good on it. Right. And now when you move to other medications, that have an impact on cardiovascular mortality or that, that are used for patients at high risk, Zetia, PCSK9 inhibitor, bempedoic acid, none of these drugs have been shown to lower all-cause mortality, whereas statins have. So they reduce cardiovascular mortality. Actually, the PCSK9s don't, but bempedoic acid does and Zetia does. But they are also the least effective. Zetia is the least effective,
But
right?
Zetia had a 17 in the SHARP trial. Zetia had a 17% reduction in cardiovascular events. I mean, obviously that's not like mortality, but it is events which can lead to mortality. Like imagine you have a heart attack. You might not have died from it, but now you have heart failure. Now you have worsening renal function, cardiorenal syndrome. Those all add up, right? That are not captured by some of these 5-year, 2-year, 3-year trials, but long term, we know what happens. But in those cases, like the statins you're talking about, the people who feel lousy on them, they're probably on some of the older statins, like the lovastatin, simvastatin, pravastatin. Those are the older non-synthetic ones that came directly from yeast or fungus, whatever you want to call it. The newer statins, like the Atorva, which is synthetic or semi-synthetic, and Rosuva, very minimal. Those are cleaner drugs, less interactions, less side effects, less, overall weird, feelings that people may have. What you could do, and what I do in these cases, put people on a lower dose Rosuva, like just 5 milligrams plus Zetia. It's as if you put them on a moderate to high intensity statin with way less possibility of side effects. And I think if we have, and the newer guidelines are probably going to support that approach where you put people on a less intense statin plus Zetia to get that moderate to high intensity statin lipid lowering and almost no side effects. So that is an option for some people that you could use, like 5 milligrams of Crestor or just 10 milligrams plus Zetia. That's what I use almost 90% of the time. And these are cardiac patients. These are secondary prevention with like LDLs that need to be below 55 and sometimes below 40. Most of my patients are on that combination and do very well and get their numbers down with almost no side effects. Now, there's always going to be somebody with side effects that says, I've tried everything, doc, this ain't working. Well, then we'll put them on Repatha or whatever it might be.
I have a hard time recommending Repatha, especially, I mentioned that readjudication. I don't know if you took a look at it, that looked at the 4-year study. And what they did was they went back to see if the cardiovascular mortality that was claimed in that study reduction, if it was actually true. And, there were some questions called in with regards to the efficacy of these drugs. And I think that the hardest part, coming back to what the patient wants to know when you're initiating a drug, 10,000 people in these studies and not one life saved over 5 years. I mean, if you say that to a patient, who's going to take it, right? 10,000 people randomized, right? And not one life was saved, right? Like that's very hard for me as a patient to even consider that drug. What do you think? Should we disregard that or?
No, I think the problem is, again, I think some of these drugs just haven't been around long enough. The original Repatha style, the 4-year trial you're talking about, there was, I think it was like 12,000 patients for like 7.9 years or whatever it might have been. And obviously there's more data now just because they've been around longer. It's been almost 12 years now. And the OLE, the 4-year OLE, the open label extension, people are still on the medication. We're still getting data back. But somebody else had criticized this trial saying, well, there was 182 deaths in the placebo arm and 186 in the treatment arm. And there was like 4, maybe 5 more deaths, whatever it was, but it did not reach statistical significance. The p-value was 0.52, which means like it's a coin flip. When you have like 12,000 people and you have 180 die in each arm, regardless of these super high risk, cardiovascular ASCVD patients, that's going to happen. But it didn't reach statistical significance. So, it was, could have been a coincidence. It might not have been. And it was actually like 0.5. So it was actually like a coin flip. But regardless, we know that almost when you look at the totality of data, evidence, medications, whatever, anytime we lower LDL cholesterol, whether it's genetics, whether it's cohort trials, whether it's dietary interventions, whether it's like we swapped out butter for olive oil, whether it's we told you to start running and eating more fiber, however you lowered LDL, we have seen a significant reduction in cardiovascular event rates and cardiovascular mortality. That's without question. I don't think that's debatable in any of the data sets.
I would caution the listener not to bog down with surrogate endpoints. That's what I would say. But
they're not surrogates. I mean, the number one killer currently, and I mean, it's down significantly, but the number one killer in the world and the U.S. especially is heart disease. And
that's in the face of the LDL lowering over the past 4 decades. Right?
But it's also in the face of higher levels of chronic disease. Like we have an obesity problem of like over 80, like it's like 79, 78% of all Americans are overweight and 40-ish are obese. So with this, once that chronic burden of disease and obesity and all that comes down even more, and we have seen a significant decrease in deaths from cardiovascular disease. Like in the 1950s, we since the 1958, I think the number is, to about 2013, we've had a 68% reduction in death from cardiovascular disease, and another 10% like every year, every decade after that. So we're
This is
making huge.
most likely catheterization, though, right? So that's most.
Oh, it's
likely
everything. It's like stents and better therapeutics and heart failure treatments and exercise, cardiac rehab, all of that, all that stuff combined, we've gotten better at treating or reducing death from cardiovascular disease.
It's just happening more and more.
What's that?
Right? It's just happening more and more, right? We're not doing a great job at preventing it.
We have more chronic disease, so generally we have more people with worse risk factors, but I think that trend is turning around now. 2023 was the first year where we now saw a dip in obesity and overweight rates, a lot of it probably due to GLPs. But I feel like going forward, if we do reduce obesity rates and all of that stuff, not that many people smoke anymore, although vaping is picking up. But if we continue to improve all those things, heart, hypertension especially as well, we continue to reduce all those things, we're going to see significant decreases in all endpoints that are cardiovascular, including dementia, stroke, all that stuff.
Would you agree that smoking causes heart disease by causing endothelial dysfunction? Would you agree it damages the endothelium?
Oh, yeah, absolutely.
Okay. Would you agree
without question.
Would you agree that diabetes likely increases the risk of cardiovascular disease by
Absolutely. We know that if you have heart disease and insulin resistance, you have a 2 to 3-fold increase in cardiovascular events and death and mortality and all that stuff, without question. That's not even, and there's a lot of things like the Inner Heart study was a study, I think, of 150,000 people, somewhere like they looked at the nine modifiable risk factors that contribute to a first heart attack, right? Like if you never had a heart attack before, these 9 things contribute the most to a first heart attack. It was number 1, lipids; number 2, hypertension; smoking; lack of fruit; lack of fiber; lack of exercise; socioeconomic, I think was number 2; diabetes, all that stuff. There's 9 things they listed. Diabetes wasn't among the higher ones; it was towards the end, but still, all of those things, contribute to that stuff. Most of my patients, probably many of yours, have any number of those things. They don't get enough exercise; they don't get enough sleep; socioeconomic, issues. Hypertension that's not well controlled, obesity rates, all that stuff combined is additive and makes the problem even worse. Now, let's say you just have one of those things. Let's say you only have hypertension, but nothing else. You eat right, you exercise and all that. Yeah, that in itself is going to cause probably a stroke. But still, like you add all those things together now, you have like a gigantic, milieu of atherosclerotic, causing problems.
If you back out obesity, if we were able to wave a wand, solve obesity, solve insulin resistance, solve diabetes, solve hypertension, solve VLDL, the epidemic of VLDL and remnant cholesterols that are out there in the world right now that's unrecognized, right?
Well, it is recognized. Remnant LDLs or remnant VLDLs or, all the triglyceride-rich remnants or whatever is captured in ApoB. That risk is in ApoB, and ApoB is a stronger, maybe more accurate is the right word, a more accurate determinant of cardiovascular risk, because all of those things are captured in ApoB. Even chylomicrons, they're very transient, but definitely all of that is captured in there.
If we address all of those, right, without addressing LDL, right,
Yeah.
and you're in this made up universe, if we address, the smoking, the diabetes, the hypertension, the obesity, the VLDL, the triglyceride rich VLDLs and the remnant cholesterols, if we address all of that without addressing LDL at all, what happens to our heart disease epidemic?
So it would significantly decrease because all of those things are accelerants. But you would still have it. I mean, it depends on how high people's LDLs are. If you still have high LDL, it's a problem. But that would reduce all of the accelerants of it. So if you have a baseline population of pretty high LDL, they're eventually going to get heart disease at some point, stroke, cardiovascular, whatever, peripheral artery disease. But you add on hypertension and smoking and diabetes and what have you. You add in all these things, it's just going to accelerate it and make it worse. I think somebody gave me the example of you're in a vehicle and you're heading towards a cliff. You can either pump the brakes and slow it down, or you can smash on the accelerator and accelerate all that. So all of these things are accelerants of, flying off this cliff that eventually could be heart disease, assuming you have like high LDL and all that stuff. So, can we make a huge headway if we got rid of most of these things with a magic wand? Absolutely. We could delay it maybe 10, 25 years from where it would be. So it really depends.
And I'm going to finish off with some quick bullet questions. I took notes here. You mentioned plaque, can't be reversed. I remember seeing, I'm going to give you a point to just clarify your statement. I've seen data showing that ezetimibe, statins, PCSK9 inhibitors can decrease plaque volume. Can you just clarify for the listener if, I've seen data for vitamin K2, decreasing calcification. I've seen data for nattokinase, reducing carotid plaques. Are all of these, so help me understand, because you said plaque can't be reversed. Which one of these statements is true or truer?
So I don't know. You talked about my cholesterol book in your email, but there is an entire chapter on plaque reversal, how to measure it, which drugs did or didn't. Once you have plaque, there's a time horizon to when it can be reversed, and there's like a huge chart in there showing the time horizon. If the plaque is fresh, like it's fresh, soft plaque, it's only like 20 weeks old, you could get an almost complete resolution. And that's why a lot of these trials where we really drop people's LDLs, like the Glagov imaging trial with the Repatha, the PCSK9s, and any of these other studies, there's a whole bunch of them. I forget, these are like as old as time, even back from my Chicago days. If somebody has fresh plaque that's under 20 weeks old, generally you will see that plaque reverse almost back down to zero. That is probably the only scenario where that can happen. Once the plaque is over 70 weeks old, it can remodel in a way where it looks like they have lower global plaque burden. Like the most recent trial that's probably the most accurate on this was the Glagov one, where they looked at Repatha, dropping people's LDLs to very, very low levels, in addition to like statins and whatnot, obviously. That did show a global plaque volume that was, much, much lower.
Zetia has been shown to lower plaque volume. Statins have been shown to lower plaque volume. Exercise, high intensity exercise has been shown to lower plaque volume.
Exercise is a two-pronged problem, because at super high levels of cardio, you actually get more fibrous, more calcified plaque in some studies. So like these extreme marathoners,
the plaque volume decreases though, right?
Yes, the overall plaque volume decreases, but you do get slightly more calcification. But it's thought to be protective, because if you're doing cardio, it's almost like, like let's say you're on lipid lowering meds, you will have the softer, more vulnerable plaque calcify and become less vulnerable. We notice like the fibrous cap gets thicker. Some of the tissue in the inside may necrose and die away because we remove some of the, atherogenic inflammatory stuff that's in the softer plaque, and it necroses, crystallizes, and looks calcified on, calcium scans and what have you. But it's thought to be protective because they do have less cardiovascular events. These people that end up being runners, or other than like the arrhythmias, obviously some people drop dead because of arrhythmias, but most of the runners and cardiovascularly fit people have less events because their plaque remodels in a way that makes it more stable.
I'm going to hit you with some couple more here. Vascepa is also been, Vascepa is a prescription grade fish oil. You're laughing. It's also been shown to decrease soft plaque and plaque volume on serial CCTAs. Quick thoughts on Vascepa. Colchicine has also been shown to reduce plaque volume, but it hasn't been shown to reduce cardiovascular all-cause mortality. So, and these are not, lipid lowering medications.
So Vascepa is prescription fish oil, like you said, but it's only EPA, whereas the other one, Lovaza, was DHA and EPA. Now, the problem is with most over-the-counter fish oils, there was a study done, and I have like the graphics of it in the book. Most of the over-the-counter fish oils don't contain any fish oil. So 95% of them not only don't contain fish oil, or they don't contain it to the levels that they say. They say it contains 1 gram or 4 grams or 2 grams or whatever, and it's only like a couple hundred milligrams. The rest is like fillers or, inert oils or maybe non-inert oils, whatever it might be. The problem with the Vascepa trials is that they use a mineral oil as the placebo, which is thought to be inflammatory, which increased the number of cardiovascular events in the placebo arm. So there's a huge controversy about that. Did it show some reduction in events in people? Let's say you've maximized everything else. You've got people on lipid lowering, their LDL's fine, everything's fine. You got their diabetes under control, but they still have high triglycerides. In those people, you could argue that maybe that's an option. Not a huge fan of it personally. The problem with fish oils is they always, there's a 69% increase in atrial fibrillation, which has been shown in almost every
6.9, right? 6.9%.
69. No, actually 69.
Oh, you're gonna have to. I'm gonna fact check that one because I don't think that's accurate.
No, it's quite high. That's the problem with fish oils. And Steve Nissen from Cleveland Clinic says, it's been a huge failure for cardiology, the whole fish oil thing. And I don't care. You could take fish oil. I'm not I'm not married to it. I could care less. You can use it in certain populations if you've tried everything else. It's probably a marginal benefit, if any, and there is a potential for harm that's quite significant. It's definitely not zero. It's it's pretty up there. So
I'm
that one, not a huge.
I'm looking at the Reduce It trial right now. It's a 1% increase in hospitalizations for AFib or A-flutter. But you're gonna have to send me that other study.
I'll send you the full fish oil trials, but of all the fish oil trials done, the composite was like 69% increase. But either way, regardless, you could still use it. AFib is not like a deadly thing. It's a nuisance. And generally speaking, we can make it go away. So I'm not too worried about that. Colchicine, like you also brought up, it is a anti-inflammatory. They had this new study called the low-dose low-dose colchicine. Low-dose colchicine is kind of like the abbreviation that they tried to make up for it. It did show a reduction in major adverse cardiovascular event rates in people with already pretty severe atherosclerosis. It's not a primary prevention trial, hasn't been shown to prevent anything. The problem with it is it causes diarrhea, but that's how it's working. You have gout patients, I'm sure, and we have pericarditis patients. You put them on colchicine, you keep titrating the dose till they have diarrhea. Now you've saturated them and it's actually working. So I don't know that one will pan out. It seems like there's more data being put on it. I think I just posted something recently showing that it did not seem to lower events in some trials, but maybe in others. So I don't know. I think the data is still out on that one. I'm also not one of these people that just jumps on the latest and greatest thing, just starts prescribing colchicine to everyone. I'm just not going to do that. You have to show me with absolute certainty that this is actually going to make a difference for, certain populations, certain patients, whatever. I'm not just going to jump on it because there's this one trial that showed something. So definitely now combination trials where you put people on multiple lipid lowering agents definitely show benefits. When you add bempedoic acid to Zetia to low dose statin or high dose statin, whatever it might be, definitely the cumulative benefit is more. Same thing when you add PCSK9, same thing when you add.
You're using statins with bempedoic acid? You would use those together?
Yeah, you definitely could. Absolutely. People who are having, let's say you're on Crestor 10, you can't really take more.
I feel like it's a great way to cause somebody to feel lousy, to do both
bempedoic
of those,
acid. No, but bempedoic acid generally is very well tolerated. There's not a lot of, weird side effects. The issue is gout.
It's just the myalgia
or gallstones.
Yeah.
I don't know that it has, the Clear Outcomes trial did not show, it had a 13% relative risk in MACE events. It lowered your LDL probably by about 20 points, depending on the person. That could be enough that what they need.
Lowered CRP, right?
It did lower CRP a little bit. It wasn't a huge thing. But, obviously the data on like final endpoints is still out there. It's a brand new thing. It was like 2023 was the clear outcomes trial, which at the time when I was writing the book, we didn't even have the clear outcomes trial, like final data finally came out. And we had to add a, new chapter on that,
I
going
think they
over.
showed cardiovascular mortality reduction, right, for bempedoic
Yeah,
acid,
absolutely.
which
It
is a,
reduced 13% relative risk reduction in CV events and mortality.
yeah, the all-cause mortality, I don't believe was statistically significant, but it
It's going to
looks,
take time.
I'd imagine. So I'm gonna come back and I'm gonna highlight because it's like 1.5 hours here, and our average, episode is about that long. I'm gonna come back to the points we probably disagree on and maybe just summarize them. It looks like when you approach cardiology, you're dealing with a population that's very sick, a little bit older, and you're looking at a sort of lifetime risk of developing cardiovascular disease, which is generally pretty high. Even in my case, well, this is not a medical recommendation. I didn't take it as such. You were estimating my risk at 90%. And so you felt that the introduction of a medication would lower my risk by, maybe 30%, or maybe potentially prevent it outright,
It
prevent
would
cardiac
prevent it
disease
outright.
outright. Yeah, I think when I'm looking at it, I look at 10-year risk along with lifetime risk, and I like to use the sort of more conservative approach when we're looking at relative risk reduction, and not, one of the things that I very much caution against is looking at each drug and drug candidate as an individual, or looking at each class as, what is the relative risk reduction, what is absolute risk reduction in the population studied. I try not to go to the concept of lifelong lipid lowering, which you do, and use the, LDL lowering as a way of extrapolating out risk. So it seems like that's like the big disconnect here with how we view medical management is, you're sort of lumping all the data together. And I'm not saying this is wrong or right. You're trying to make a really good guess, which is probably it's not always, doesn't always pan out like in the case of a cord, but sometimes it absolutely does pan out. And you're saying, 40 milligram per deciliter lowering of LDL will achieve a 20%, risk reduction. Whereas I'm saying this drug, will give you a 20% relative risk reduction. And then besides that, it didn't really seem like we disagreed on much. We both agreed on that insulin resistance, obesity, hypertension, that these are accelerants of heart disease and absolutely need to be focused on. I think you embrace pharmacology more than I would. Any other
But
points
don't
you
forget,
think
my population is really sick. I mean, your population, probably not many of them have had a heart attack, and they're more primary. My population's like they've absolutely had a problem, and they need to not have further problems because I'm not doing my job.
Yeah. And any other points of disagreement you think are worth highlighting while we're here? And you got the last word, so you can plug your book, you can plug wherever people can find you as well.
Well, I mean, I didn't want to, come on here to plug anything really. I just want people to get good cardiac information and how to prevent heart disease. I think you're doing a good service, hopefully helping people kind of at least understand this, or at least understand how physicians would approach this. A primary care physician who's focused on prevention, and a cardiologist who has a lot of secondary prevention, as well as, being a preventive cardiologist trying to prevent further, disease in new people who've never had it. I think it's important for people to kind of understand our thinking process as to why we think of these things, how we think of them, the logic that we use, our analytical, minds or brains, or however you want to do it, how people approach the data, how we synthesize it, how we think of it. Those kind of things I think it's an important look, I think, for the general public to see how physicians think of things, and what kind of calculations or, ideas are going through our heads, how we approach various different patients. Yeah, I did. I published a book with Thomas Dayspring. It's called Cholesterol Truth. It goes over a lot of this stuff, like literally every study you mentioned, including Accord and Advance, and all of those are in there. There's over 800 studies that we go over. I think you would like it. Shoot me your address. I'll send you a copy of it. I think you would really enjoy it.
I'll take a look. Dayspring has called me an embarrassment to medicine. So you're going to have to apologize for not rushing to go
He's
buy your
called me
book.
an embarrassment to medicine too, and I think it's fine. I mean, it's the internet. People say all kinds. I don't think he really means it. I think you're doing a good job, obviously, getting the word out there about a lot of things. But definitely, yeah, I'll shoot you a copy. I think you'll enjoy it because it goes through every single study. It's full color, 600, almost 500 some odd pages. You would like it, but definitely, I think we probably agree on a lot more. I think our dietary patterns are probably different. You follow a more low carb keto style diet. I follow more balanced Mediterranean style diet, but I don't discourage my patients from doing any diet that they think they can adhere to long term, because the fact of the matter is, if you lose weight, generally speaking, no matter how you lose the weight, your inflammatory markers go down, your cardiovascular markers generally improve, kind of depends on the person. But most of your cardiovascular slash other outcomes generally will improve with the weight loss, almost regardless of how you diet or eat, as long as weight comes off. So I think that might be the only thing we seriously disagree on. I think the other stuff kind of, depends on your patient population.
We can come back and we can discuss that. I had that written down in my notes here to tackle, but I don't think we're going to have the time. I have strong opinions on dietary interventions. I think one of the harms we've done, having been a patient with obesity, is equating diets. And I think we should move away from equating diets and emphasize the differences of the diets, what they accomplish, what they're used for. For example, if I wanted to lower my LDL, I certainly wouldn't exclude more carbohydrates. Likewise, if I wanted to lower my blood sugar or improve my muscle mass, I may not look to add carbohydrates. So, I think that's something we can do a better job of, being very nuanced. I think the idea of saying any diet you can adhere to, while it's true, it's I don't know that it's helpful. People want to know what diet they should do, right? And I think
completely agree.
Yeah,
I think, but a lot of patients, like, you know this, maybe not in your practice, but in my practice, patients like barely do what you ask them to do. I'm like, listen, you need to start exercising, you need to start losing weight, you need to start doing this. No matter how much we say that, we've done a pretty bad job. It's not like the doctor's fault. Like, it's also a lot of it is on the patients. They don't care if they can sometimes just take a pill and think that magically helps.
I think this is another point of disagreement, right? So I think it's, and this is my passion in medicine, is, you said it's not always the doctor's fault. I think we have to start, accepting the health of our patients. It will be it should be our fault, right? If our patients aren't,
absolutely,
right? If we can't, we should tie our payments to our patient outcomes. I'm a firm believer of value-based care, and I think very quickly you'll see that, physicians become a lot more interested in motivating patients and, helping them with diets and helping them adhere and figuring out how to do this lifelong and thinking about their quality of life and what they can do. So I'm a big believer in value-based care. So this is another point of disagreement.
I agree with that, but I think the problem is
not
the way
the patient's fault. I think it is the patient. It's not the physician's fault. I think it is.
Look, it's a total
that's okay to disagree. Yeah.
No, it's a system-wide problem. People paying to this third-party system that is the health insurance system, and there's no incentives on that part. Like, let's say you're Blue Cross Blue Shield. They don't tell you, hey, listen, if you lose a bunch of weight, stop drinking, stop smoking, you only have to pay $10 a month, right? They're like, there's no motivation for that. So I think the whole system is set up in a way where, like you said, it's more like we're trying to patch people up instead of prevent things. And I don't know, from a public policy standpoint or any of that we're going to change that anytime soon. I would love to, and I would love to build incentives into physician payments and patient payments and reducing their, cost of health insurance and all of that. I think there's a little bit, if some insurance,
but there's incentives if you, prescribe, flu shots and statins, right? We have incentives for those, right? So I think
I don't know
incentives are
it depends. I'm in private practice, so nobody really can tell me what to do. But
but the insurance companies do give those incentives,
they
right?
will send you a thing, but you don't get paid for it. They'll send you a thing say, "Hey, your patient's diabetic. Is there a reason why they're not on statin?" I'm like, "Yeah, their
You need to
LDL's like
get into an
50."
IPA because the IPAs will get you those incentives. Then,
Well, yeah, I don't even know. I don't even know what that is.
yeah, it's an
But
independent physician organization, or yeah, pretty much
we
what
don't
led.
have that. We're
Yeah,
just a
you'll
private group. We could do pretty much whatever we want. Now they'll send you a letter saying your patient has XYZ. You should probably check ABC. Okay, some of that's reasonable, but I don't get paid for that. It's like, oh, a patient needs a cholesterol screening or a
a
colonoscopy.
lot of the private practices left standing in the United States are part of IPAs that are rewarded based on testing less, like cost conscious care, promoting vaccines and recommending certain medications that are believed to be, standards like statins. And
Sure.
so they're rewarded for sort of, robotic care. And I feel like that's a huge problem. We should be, like you said, rewarding on patient outcomes. And if we reward on patient outcomes, doctors will really quickly learn what's actually helping people and what's not. And it'll solve the problem of, how aggressively we should use statins or not, because you will be paid less than I would, or I would be paid less than you would. So anyway, that's my hope. I'm going to put the book in the show notes, and then I'll put your social handles in the show notes. Thank you so much.
Yeah. Thanks for having me.